This is Dr. Cobb from Pennsylvania. Thank you.
All right, so this is a little bit higher. There we go. IVC filter removal. These are my conflicts of interest. So I'm going to start off with what most academics do is with a paper. So this is a PRESERVE trial from 2023, and it summed up whether or not the safety and effectiveness of IVC filters over time. It was a prospective non-randomized trial in 54 sites from 2014 to 2019, evaluating 1,400 patients. The primary safety endpoint was freedom of perioperative serious events from clinically significant perforation from the filter embolization, cable thrombosis, DVT, all within 12 months, and the efficacy is comprising procedural and technical success and freedom from new symptomatic PE confirmed by imaging. They studied in this trial a handful of filters. I don't know why they included the the trapeze, which is not available anymore. And my institution, we predominantly use the Denali and the Venatech. I don't know anybody that uses the Crux, to be honest, but the other ones we do see occasionally. So basically, I'm going to skip through the results because of time, but the primary safety and effectiveness results basically said that you can place these safely within 12 months, and they do work. The key point is within 12 months, and I'll get back to that later. They had only 23 clinically significant non-fatal PE after filter placement, and that's 71% of these patients had a current VTE at the time of placement. The clinically significant filter-related adverse events were extraordinarily rare, and post-filter placement DVT was low at around 5%, cable occlusion around 1%, and filters were removed 98.8% of the time, with close to 97% of them removed at first attempt, which is good to see because we have a filter removal program. Once we place a filter at Penn, they have scheduled follow-up with us until that filter comes out, which is a soapbox I'm going to continue to stand on. All right, so the conclusions is always plan for retrieval at the placement with frequent reevaluation. So scheduling and capturing those patients at placement for a 3 or 6 month follow-up works. It is part of the SIR guidelines as well for filter placement. So here are the meat of the talk is more filter removal techniques. If you do not do these frequently, please do not attempt them. A lot of patients that come to us with a cable occlusion or with horrific complications are because somebody wanted to remove a filter that they may or may not have tried to remove, should have been trying to remove. And you should be able to determine that off your pre-procedural imaging, which we routinely get CTVs, but not necessarily for non-complex cases. So if you don't, it's a short duration. If there was a pretty standard patient, we just do a rotational cavogram on the table instead of doing a pre-op CTV. And I've only had that backfire on me like once where we couldn't remove the filters the same day. But clinical history is very important. Procedural imaging, we do a rotational cavogram with 15 cc's per second for 90 seconds. So that's the 6 seconds that it takes our C-arm to kind of go around and do the rotational cavogram. And based off of that, you can see whether or not it's tip embedded, whether or not there's cable thrombosis, how tilted it is. Your pre-procedural imaging will also show whether or not it's fractured. And on this one, as you can see, only in one of the projections, the tip is actually protruding towards the spine. Which will then determine what you're going to use for removal. So we use a lot of the Merit end snare, one snare. We have those just on our shelves, plus the Cook vascular retrieval set, which during COVID, the normal retrieval set was on back order, at least for us. I don't know about for you. So we had to use the 4-loop vascular retriever set when we typically use just the single loop snare. For the advanced techniques, we have, once again, we stock all of these. If you're planning on doing these procedures, just make sure that you have these sorts of things to bail yourself out, including 18, 16, 14 French sheaths for the different devices, as well as a Gore dry seal sheath. And the newer on the market is the Inari Protrieve. If you're going to use endobronchial forceps, they are not longer than the Protrieve sheath. So that's just a heads up, and I learned that the hard way. They will not go out the end of the Protrieve sheath. This is that Protrieve sheath which was mentioned earlier. It's a 20 French inner diameter, but 26 outer diameter. They actually have a newer version of it that's not this picture, but they're trying to make that handle smaller, so hopefully eventually we can get endobronchial forceps through it. It has a expandable funnel that prevents any PE from getting beyond it. One of the techniques you can use for a tip embedded, if you don't have forceps, you're not used to using forceps, is you can go in and you can do a hangman approach. I like to use a reverse curve catheter, get between the neck of the filter and the caval wall, and then you kind of loop it up and get into that hook that's covered in fibrin and collagen. So this is just an illustration from that paper. So you get in, this looks like they're using a sauce, you snare your wire. We use a monofilament wire like a, what's it called, like a glide wire. That way you won't unravel anything like an Amplatz or a Benson. You can basically pick up a patient off the table using a glide wire. The fallback loop snare technique, it's very similar where you basically just snare underneath the neck of the filter itself and then pull it through. For the trapeze and optes filters, you can use this double snare technique where you grab them from above and below because they're a closed cell symmetric geometry. So you want to grab it at the top and at the bottom, pull tight, that narrows it down, and then meet your sheaths in the middle. Remember, you don't want to pull, you want to advance with back tension. So that's what it looks like out of the patient. The jaws of life technique, do a lot of these. We did this one recently for a tip embedded option elite. Come around it, kind of use a sweeping dissecting motion to get the hook. And I like to get I have a lot of fellows, so what I make them do is get that picture on the far left where you can see directly down the jaws themselves to show that you've got the hook of the filter itself. And then this is that sweeping technique I was talking about. You open them up and you want to pull them back. You don't want to necessarily advance forward once you get the tip. And then you get your sheath down, and at the very end, a little bit of a pop. And it's usually satisfying. Just feel that right there. I don't know, I like it. So the ragdoll version, this is for an ALN filter. Bill Stavropoulos did this case. So basically that tip is almost completely outside of the cava, so it's just like, well, shit, what do I do now? So what we did is you bring your wire down, bring your forceps down and you grab it by the neck and then just pull. So he grabbed it a little bit lower on that second grab, but then eventually got it up and out and got all the fragments out. We're also very experienced in foreign body retrieval, so if one of these legs flies to the lungs, we already have everything in the room to go ahead and do that. Once again, that's another warning to say only use it if you know what you're doing. So finally, lasers. There's some laser sheaths out there. I don't know if individuals use them for like lead removals, as well as some people use them for recans within the stents. I know my colleagues down the street at Jefferson do that instead of power wire because then they can get through the occluded stents without perforating the side or shorting out the machine like I frequently do with power wire. This is the CavaClear system by Philips. It's really good for the closed cell stents that have scarred into the wall of the IVC. I'm currently under a political battle to get this in our department, but the purse holders are not allowing me to do it. But this is so you go down, you engage the fibrin, you engage the collagen, and then you apply the laser. The laser is supposed to shear it off the walls, and then you get a nice little pop right there. It initially started for removal of ACD leads and pacemaker leads. So these are the different Philips laser sheaths. The CavaClear is the newest one. They have the 14 and the 16. It does come in 50 centimeters. Your endobronchial forceps are 65, so it should work. I personally believe the best way to remove a filter is by never placing one. We get a lot of patients that come in with filter disasters, and you look through their history and you're like, they didn't even need a filter in the first place. I have a guy who has venous ulcers because of that. So no, the way that you don't place one is by talking about the guidelines from all of the societies like CHEST, from SIR. I like this one from hematology. I feel like I should hand it out to the interns on medicine services every July. But this tells you in very plain form when you should not place a filter. As I try to remember the residents, it's a consult, not an order. So if they say that they need a filter, you look at the patient, you work them up, and you decide whether or not it's our recommendation to place a filter. Good thing about filters is now there's like that whole filter out Friday if anybody's on social media. So every Friday my Twitter, I guess now X, is like littered with filter out videos.
Thank you. That's really a comprehensive review. Thank you very much. I want to ask you, have there been any perforations with that laser, Philips?
So I don't use the laser as much. I imagine that there have been. I don't know what the reported data is.
Yes.
Yeah. Yes, there you go. There's the answer. We
Yeah.
stick to the traditional
Part of the
techniques.
problem with the laser is it would be perfect if it could be used with a forceps, but since you have to use it with a hook because it's too small for the forceps, it makes it really hard for those embedded filters because then you can't do it with forceps.
They have the newer 16, though. I think the 16 can fit the force. It doesn't?
I don't think so. You have to
Good to know.
be careful not to push it forward.
Yeah.
So if you push it forward, perforations are common. As long as you can push it forward as long as you have tension backwards.
Yeah.
If you want it pushing everything forward, it can easily make a perforation. The thing for your purse holders, you said you didn't have it, is there's a pass-through payment this year. So there's a pass-through payment approved.
Okay.
So currently, there's no direct code for it, but there's a code for the pass-through payment. So your institution won't lose any money currently if you're using it.
Interesting. We'll bring that back to the...
I have a thing if you want to give me your number. I'll send it to you.
I had a couple of filters that I had to remove open. One that it was in the aortic wall, one that it was in a side branch, and one that was in the spine. Did you have any of these? And did you have any open removal in your series?
The only one that we had recently was, it was unfortunately placed in the aorta, directly into the aorta. Which was an interesting case because how they didn't catch the blood flowing the wrong direction on their final run, and then it was found on the follow-up CT on the inpatient was interesting. It was not placed by our group. But that one went open. The rest of, yeah.
Nice.
Thank you. Thank you very much.